Hi, and thank you so much for coming to my talk today. My name is Elizabeth Wall-Wieler, and I'm an assistant professor at the University of Manitoba in Canada. And today I'll be talking about a study I conducted during my postdoctoral fellowship at Stanford University, where I examined the relationship between benzodiazepine use before conception and risk of ectopic pregnancy. Before I get started, I'd just like to acknowledge the wonderful people that I got to work with on this study, including Drs. Susan Carmichael and Deirdre Lyell from Stanford, Dr. Holly Rabakis from Mount Sinai, and then Drs. Robert Platt and Reem Baswarwa from McGill University. I'd also like to acknowledge my funders, Banting and Stanford's MCHRI, and data support from the Center for Population Health Sciences. A bit of an overview of my talk today. I'll start by giving you a bit of a background on the concepts around ectopic pregnancy and benzodiazepine use, and then I'll go into the data and methods that I used to conduct my study and the results from the study and a bit about the limitations, and I'll end with a brief discussion of the implications. So a bit of a background. So ectopic pregnancy occurs in about 1% to 2% of all recognizable pregnancies, resulting in about 126,000 pregnancies every year in the United States. Ectopic pregnancies can be are quite serious if they're not treated early. They can result in up to 6 to 13% of all pregnancy-related deaths, which is often due to hemorrhage from ectopic pregnancy, which is the leading cause of pregnancy-related death in the first trimester. And for those ectopic pregnancies that don't result in death, there's also serious complications associated with them, including hysterectomies and blood transfusions. So most ectopic pregnancies implant in the fallopian tube, and this occurs when there's changes to the tubal environment that result in premature implantation. Although ectopic pregnancies are not that rare and have pretty serious consequences, our understanding of what risk factors are for ectopic pregnancy is pretty limited. In fact, about half of ectopic pregnancies don't have any known risk factors. Risk factors that are known include pelvic infections, STIs, assisted reproductive technologies, intrauterine devices, smoking, and increased age. A potential risk factor that has not been examined before now is benzodiazepine use around conception. So benzodiazepines enhance the effects of the neurotransmitter GABA at the GABA A receptor, which results in sedative effect, including muscle relaxant properties. And these receptors are located in the fallopian tube, which could potentially affect muscle contraction, leading to increased risk of ectopic pregnancy. Benzodiazepines are actually pretty common, prescribed in the United States. About 13.5 million adults in the United States filled a prescription in 2013. The most common indications for benzodiazepines are anxiety, insomnia, seizures, and acute alcohol withdrawal. Some of the most common benzodiazepines are alprazolam or Xanax, clonazepam or Klonopin, and then lorazepam, or more commonly known as Ativan. These drugs are also pretty commonly used by women of reproductive age. In fact, about just under 4% of women between the ages of 18 and 35 had at least one prescription of benzodiazepines. So in this study, our research question was, are women who fill a benzodiazepine prescription around conception at increased risk of ectopic pregnancy? To look at this research question, we used data from the IBM MarketScan research databases from years 2008 to 2015. So this database includes information from more than 200 US commercial health plans, which cover about 50% of the US population that is covered by employer-based insurance. And through this database, we have access to inpatient services, outpatient services, outpatient pharmacy prescription claims, and healthcare enrollment information. We use this information to identify pregnancies using predefined algorithms that used a series of diagnosis and procedure codes. And then we compared benzodiazepine use among women who ended up having an ectopic pregnancy and women who had an intrauterine pregnancy, which included live birth, stillbirth, spontaneous abortion, and induced abortion. And this data set also lacked information on gestational age or date of conception for these pregnancies. So we used an additional data algorithm that had been developed using the same database to estimate the date of the last menstrual period, to which we added 2 weeks to estimate the date of conception. So identifying benzodiazepine use is also a little bit tricky. So we can identify prescriptions from the outpatient pharmacy files to see who filled a prescription for benzodiazepines, but benzodiazepines are not meant to be taken every day. They're meant to be taken as needed. And so someone could have a prescription for benzodiazepines for a long time and only take it very occasionally. And we wanted to capture individuals who are most likely to have taken these medications around conception. And so we defined our exposure as individuals having at least 2 benzodiazepine prescriptions, totaling at least 10 days supply in the 90 days before the estimated conception date. So this, having at least 2 prescriptions increased the probability that these individuals were actually taking this medication on a pretty regular basis. And having at least 10 days supply excluded individuals who had a benzodiazepine prescription, perhaps for a surgery or other procedure that resulted in anxiety for them. So in our study, we started out with just over 4 million pregnancies. Then we excluded those who didn't have an insurance plan with a prescription drug coverage and those who were under-enrolled. So this was individuals who didn't have complete coverage or continuous coverage from 1 year before the start of the pregnancy until the end of the pregnancy. And then we also excluded those who had limited benzodiazepine exposures. So this was an individual who had at least 1 prescription for benzodiazepines but didn't meet our exposure definition. So our final cohort had just under 1.7 million pregnancies. We then looked at the relative risk of ectopic pregnancies using log-link binomial models, and we adjusted using inverse probability of treatment weights, which were derived from high dimensional propensity scores. So to derive these propensity scores, we included 7 predefined variables: age, year, sexually transmitted infection, assisted reproductive technologies, pelvic infection, intrauterine devices, and then we also let the algorithm choose the top 500 covariates from the different health databases that were associated with the exposure, which was benzodiazepine use, and or the outcome, which was ectopic pregnancy. We first looked at the relative risk of ectopic pregnancies for all benzodiazepines for the whole population. Then we looked at it by type of benzodiazepine, and then to identify or to look at confounding by indication. We also had 2 analyses limited to individuals who had specific indications. So first, those who had anxiety diagnosis, and then those who had an insomnia diagnosis. And then we did a sensitivity analysis to identify how our definition of exposure affected our outcomes. So first, we just looked at everyone who had at least 1 prescription of benzodiazepines in the 90 days before. And then in our more strict definition, we identified those who had at least 2 prescriptions totaling at least 10 days supply in the 90 days before conception, but at least one of those prescriptions had to be filled in the 30 days before conception. So when we looked at our first analysis where we examined any benzodiazepine use in the 90 days before conception, we identified that those who had a benzodiazepine prescription, the risk of ectopic pregnancies was about 257 per 10,000 pregnancies compared to 177 per 10,000 pregnancies among those who did not have a benzodiazepine prescription. When we adjusted for the inverse probability of treatment weights, we had a relative risk of 1.47, indicating that women who had a benzodiazepine prescription before conception were about 47% more likely, had a 47% greater risk of having an ectopic pregnancy. Then when we looked at specific benzodiazepines, we saw that for all except for clonazepam, the risk was pretty similar, around 1.5. When looking at the outcomes by indication, we saw that among women who had anxiety, that the relative risk of ectopic pregnancy was still significantly higher at 1.33. And then when looking at insomnia, those who had an insomnia diagnosis, we saw that the relative risk of ectopic pregnancy was about 1.28. And then lastly, we had our sensitivity analysis. And so using the less strict definition, so this was just 1 benzodiazepine prescription in the 90 days before conception, we saw that the relationship was still significant, but the estimate was not quite as strong. So an IPT weighted relative risk of 1.27. And then when we had the stricter definition, where we required at least one of the prescriptions to be filled in the 30 days before conception, we saw that the relationship was stronger at 1.54. So there was several limitations about this study that we should take into consideration when thinking about our findings. First, we had to use algorithms to identify both pregnancy and to define conception. This could result in misclassification. Then second, we were relying on outpatient prescription data to identify medication use, and this could either over or underestimate the actual use of benzodiazepines. So it could overestimate benzodiazepine use for individuals who filled a prescription but didn't actually take it, and underestimate it for individuals who received their medication in an inpatient setting or who paid for their medication out of pocket. We also had pretty limited access to sociodemographic characteristics, so could not adjust for those. And we only had women who had employer-based medical coverage included in this study. So I'm not sure if these findings are generalizable to other populations. Regardless of these limitations, there are some pretty important implications for this study. So first, we found that, we think that women who have an indication for benzodiazepine use, particularly those who plan to become pregnant, we should provide them with information regarding the potential effects of benzodiazepines on their reproductive health. And then second, for women who are using benzodiazepines and become pregnant, particularly those who have other risk factors for ectopic pregnancy, we should lower the threshold for early pelvic ultrasounds to assess for intrauterine or ectopic pregnancies. So these early ultrasounds could identify the ectopic pregnancy, which would result in earlier treatment, which could prevent the worst outcomes. So this study has been published earlier this year in the Journal of Human Reproduction. So there is a lot more information available in that study, but I'm also happy to answer any questions. Thank you.